First, I'll describe details about migraine, and after that, I'll discuss about newer drugs or newer therapies available for it. So, what are the common causes? So, it includes definition of migraine, classification of migraine, diagnostic criteria, causes of migraine, signs and symptoms of migraine, management of migraine, and signs and advances. So, what is migraine? So, according to definition, it is a type of severe recurring headache that causes intense throbbing or pulsating pain in one area of the head. It is often accompanied by few additional symptoms such as nausea, vomiting, and sensitivity to light or sleep. Migraine is the second most common cause of headache. The most common headache-related and indeed neurologic cause of disability for travelers. It almost affects around 15% of the women and 6% of the men over a year. So these are the types of headache as shown in the image. This is tension headache, which includes almost whole area, while migraine is a unilateral type of headache. Cluster headache is one thing, sinus headache on the side because of sinusitis, hypertension headache, whole head, and TMJ headache. That is temporal. Now we have classification of migraine. So migraine without aura, migraine with aura, which is also called as classical migraine. Then migraine with brainstem aura, menstrual migraine, hemiplegic migraine. So this is the aura which is seen, which is like rainbow appearance. Then how you will diagnose migraine? So according to these, a headache which is lasting for 4 to 72 hours in a patient with normal physical condition, no other reason involved and at least 2 of the following symptoms, which includes unilateral pain, throbbing pain, allergy, moderate to severe intensity, and at least one of the following. What are the causes of stress is the main cause of the migraine. Others include glare, bright light, sounds, hunger, letdown from stress, depression, stormy weather, barometric pressure changes, hormonal fluctuation, lack of sleep or excess of sleep, etc. Another pattern. According to pattern, so one theory is vascular theory. So according to vascular theory, initial vasoconstriction, which means something plus cerebral ischemia and attack. What is neurogenic theory? According to neurogenic theory, there is a local situation of inflammatory behavior such as fibrosity and hydroxyapatite, neurotransmitters, CGR, etc., which leads to inflammation and vascular pathway. So what are the symptoms? This includes simple analgesics, NSAIDs, 5-HT receptor agonists, ergot alkaloids, triptans, CGRP antagonists, dopamine receptor antagonists, opioids, monoclonal antibodies, and miscellaneous. Now we have non-pharmacological treatment of migraine. So there are 4 currently, which is given in Harrison 21st edition. So it says single pulse transcranial magnetic stimulation. So pulse disturbs abnormal neuronal activity associated with migraine. Then others are non-invasive vagal nerve stimulator, remote electrical neuromodulation, transcutaneous supraorbital nerve stimulation. Now we'll start with drug therapy. NSAIDs. NSAIDs, they reduce both severity and duration of migraine, less effective in moderate to severe attacks, more effective if taken early. We'll start with paracetamol and then we'll shift to other drugs. Side effects include dyspepsia, GI irritation, etc. Few drugs other than paracetamol is ibuprofen, naproxen, diclofenac. Excessive and long-term usage leads to rebound headache because whenever we withdraw the drug, pain usually recurrence of pain occurs. So this is the case, this is why it is responsible for rebound headache. Then we have ergot alkaloids. Uh, NSAIDs because NSAID works via COX inhibition, while ergot works via uh, 5-HT agonism. But this 5-HT agonism is non-selective. Nasal formulations are available. Vasoconstriction induced by ergotamine is long-lasting and decumulative when taken repeatedly. Because of this, there is erratic oral absorption. There are frequent side effects such as nausea, vomiting, muscle cramp, etc. It is only used when triptans fail, and due to non-selective action, these are rarely used now. Triptans. So triptans are selective agonist at 5-HT1B, 1D receptor. So basically, activation of these receptor leads to constriction of cranial blood vessels, including AV and anastomosis, and which closes shunts. Alternative hypothesis suggests serves as a presynaptic autoreceptor that blocks pro-inflammatory neuropeptide. Also, there are available as oral, nasal, and subcutaneous. Side effects which includes paresthesias, flushing, pain in chest, neck and jaw, coronary vasospasm, rebound headaches are one of the causes why we are looking for more modified and more developed treatments for migraine. These are few examples: sumatriptan, Riza, triptan, alitriptan, aratriptan, for provatriptan, almotriptan, zolmitriptan. Then we have DTANs. Now we'll start with the newer drugs. This was approved, FDA approved in 2019. It is a selective 1HT, 5HT, 5HT1F agonist. Doses which are available as 500, 100, 200 milligram orally. It is only used in acute attack of migraine. Few side effects are paresthesias, dizziness, nausea, vomiting, etc. Hence, patients are not advised not to drive after taking meds. Then we have CGRP antagonists. CGRP antagonists such as Ubrogepant and Remgepant are FDA approved only for acute attacks. Few side effects such as nausea, somnolence, urticaria, etc. These are contraindicated with other CYP3/4 inhibitors. Here are few examples of CYP3A4 drugs such as C for cyclosporins, CCB, tacrolimus, statin, C for cisapride, estimizole, terfenadine, E for amiodarone, and for NAVERS, which are protease inhibitors such as ritonavir, atazanavir. Doses of Ubrogepant is 550 to 100 milligram oral, and Remgepant is 75 milligram oral. Now we have monoclonal antibodies. This is adalimumab CGRP antagonist, which was FDA approved on 2018. Doses available as 70 to 140 subcutaneous once a month. Then we have fremanzumab, similar mechanism of action, available as dose 2 to 5 to 675 milligram SC every 3 months. Then we have glacazumab, same. It is available as 240 milligram subcutaneous loading dose, followed by 120 milligram subcutaneous monthly dose. Then we have eptinezumab CGRP antagonist. So this is the latest one, which was approved in 2020. It is given as 100 mg IV infusion over 30 minutes every 3 months. So for summary, what are the newer drugs available for us are: first is DTANs, which is selective 5-HT1F agonist. Then second is GPAN, CGRP antagonist. Then we have monoclonal antibodies, which directly act against CGRP. Neuropeptide. Then we have neuromodulation such as single pulse transcranial magnetic stimulation, non-invasive vagus nerve stimulator, etc. Ultimately, please prefer to avoid few triggers of migraine by knowing your food trigger, eat regular meals, avoid excess caffeine, exercise regularly, get enough sleep, reduce stress. Thank you so much.